Welcome to this video on testosterone replacement therapy. Testosterone replacement therapy has several benefits, especially with age. These include improvements in libido, erectile function, bone mineral density, and hemoglobin levels. Some studies show statistically significant improvements in mood, mobility, and depression scores. However, consistent improvement in cognitive function has not been demonstrated. Overall, testosterone therapy is associated with reported improvements in quality of life, libido, depressive symptoms, and erectile dysfunction. These potential benefits should be considered in appropriate patients. Symptoms of low testosterone to consider in men include erectile dysfunction, loss of libido, loss of early morning erections, gynecomastia, sweating, hot flashes, osteoporosis, low-impact fractures, or known pituitary disease. When exploring the causes of testosterone deficiency, it is useful to differentiate between primary and secondary disease. Primary testicular causes include Klinefelter syndrome, mumps or chitis, testicular damage from radiotherapy, chemotherapy or surgery, and a history of undescended testes. Secondary causes relate to hypothalamic or pituitary disease, such as pituitary lesions like prolactinoma or Cushing syndrome. It is important to assess for red flag symptoms suggestive of pituitary disease, such as headaches, visual disturbance, or galactorrhea. Additionally, several non-gonadal and contributing factors should be considered, including obesity, type 2 diabetes, and hemochromatosis. The use of certain medications, such as glucocorticoids, opioids, and some antipsychotics, as well as previous exposure to radiotherapy or chemotherapy, can suppress testosterone production. In the context of obesity or type 2 diabetes, low testosterone with low LH and FSH may suggest non-gonadal illness. Management should focus on metabolic control and weight management first. Clinical assessment should include blood pressure, height, weight, BMI, and waist circumference measurements. Examine the external genitalia and assess testicular volume, often using an orchidometer or clinical estimation. When testing for testosterone deficiency, measurements should be taken on 2 separate occasions, at least 4 weeks apart. Timing and fasting are important factors. Testosterone should ideally be measured using an early morning, fasted blood sample, typically between 7 and 9 a.m. Levels greater than 12 are generally considered normal, while levels below 12 are low. If the initial testosterone level is low, repeat the test after 4 weeks, along with measuring LH, FSH, prolactin, albumin, and sex hormone binding globulin. For borderline levels, free testosterone may need to be calculated. Low testosterone with low LH and FSH or raised prolactin may indicate a pituitary lesion, requiring referral to endocrinology. Conversely, raised LH with low testosterone suggests primary testicular failure. When initiating treatment for testosterone deficiency, suspected secondary hypogonadism should prompt referral for specialist endocrine assessment. Baseline investigations before starting testosterone treatment should include PSA, full blood count, hematocrit, liver function tests, lipid profile, and HbA1c. Before considering testosterone therapy, address lifestyle and reversible factors first, such as weight loss, optimizing comorbidities, reviewing medications, and managing cardiovascular risk. Erectile dysfunction should be managed appropriately, for instance, with PHOS-PHO-DIESTER-ASE5 inhibitors like sildenafil where indicated. Testosterone replacement has not been shown to improve glycemic control or prevent progression to type 2 diabetes in men with prediabetes and low normal testosterone. It should not be used specifically for diabetes prevention. It is essential to be aware of contraindications before starting testosterone replacement therapy. It is contraindicated in men with known or suspected prostate cancer, or those under investigation for it. Testosterone therapy is also contraindicated in men with male breast cancer, raised hematocrit, known thrombophilia, severe heart failure, recent myocardial infarction or stroke, or severe untreated obstructive sleep apnea. Importantly, testosterone replacement should not be used in men who have not completed their family, as long-term use can suppress spermatogenesis and lead to loss of sperm count. Testosterone replacement therapy is most commonly prescribed as a transdermal gel or pump, or as an intramuscular injection. Oral testosterone undecanoate is available but rarely used due to fluctuating levels and concerns about liver injury. Potential side effects include polycythemia or raised hematocrit, which increases the risk of thromboembolic events. Other possible side effects include gynecomastia, leg swelling or edema, acne, and skin reactions. Some adverse effects are preparation-specific. Intramuscular injections may cause pain at the injection site and fluctuations in mood, energy levels, and sexual desire. Transdermal testosterone gels are associated with skin irritation, variable absorption, and the risk of interpersonal transfer. Application sites should always be covered with clothing. Accidental transfer of transdermal gels to children can cause harm, with reported cases of genital enlargement and premature puberty due to elevated testosterone levels. Following initiation of therapy, patients should be reviewed at 3, 6, and 12 months, and then annually thereafter, with assessment of symptoms and cardiovascular risk. Monitoring should include testosterone levels, aiming for a total concentration of 15 to 30. Sampling times vary depending on whether a transdermal or intramuscular preparation is used. Hematocrit should be monitored closely. If it rises above 55%, consider dose reduction, changing preparation, or cessation of treatment. Any rise in PSA should prompt discontinuation of testosterone therapy and referral to urology for further assessment. The potential risks primarily relate to cardiovascular and prostatic health. Evidence suggests a possible increased risk of cardiovascular events, including myocardial infarction and stroke, as well as venous thromboembolism. There is also concern regarding a potential increased risk of prostate cancer. These risks must be carefully discussed with patients and weighed against potential benefits. Please like, subscribe, and share this video to help support the channel. Thank you for watching.